Welcome to Distance is No Obstacle, the medical education podcast aimed at providing bite-sized education and information for doctors working in rural and remote Australia. Today we chat with Dr Tom Shannon, a urological surgeon at the Prostate Clinic. This is the second of two podcasts. In this podcast, Dr Shannon discusses general urology issues that come up in general practice. He's joined today by Dr Olga Ward.
In our last podcast, we talked a lot about prostate cancer and men's health in general. But of course, urology isn't just all about prostate cancer. And I thought it would be nice to get your take on a few other urological things that come up in general practice.
Absolutely.
So not every bloke with urinary problems has an enlarged prostate.
No.
What else are we looking out for?
Well, so it's probably better to think of it as a complex of symptoms. It was renamed quite a while ago from prostatism into LUTS, which means lower urinary tract symptoms. And as a way of explanation, the symptoms that men get are an interplay between what the bladder's doing and what the pipe's doing. And as men get older, prostates get bigger, and that can cause obstruction. But probably a lot more of what I see is not a physical obstruction from enlarged prostates, because when men have a very big prostate, a lot of those guys have no voiding symptoms at all. So it's not the size that really matters. It's the interplay between the bladder and the prostate. And what we need is this really nice funnel shape to be created when we want to wee, so that the water has a laminar spiral flow and it comes out really strongly. And you can't achieve that if you've got an extra lump on your prostate protruding in. You can't achieve it if you've got a very high bladder neck. You can't achieve it if you've got very tight muscles at the bladder neck. And so it's really not all about the prostate and about the size of the prostate. And it's a little bit of why the DRE can lead you astray. So we have these symptoms that we look at. I have this mnemonic they call WE is fun, WIISFUN. And the FUN is frequency, urgency, nocturia. And that's really due to your bladder. So as the bladder is obstructed, it's like any muscle, it gets thicker and stronger. But by getting thicker and stronger, it becomes a better pump, but it loses its elasticity, so that when it's full, and you've got to go. So, and that manifests as frequency, urgency, nocturia. So we always ask those symptoms. The WE is fun. W stands for weak stream. So men might complain that the stream's weak. I is intermittency, and intermittency means stop and start. The other I is incomplete emptying, and if men are telling you their bladder's not emptying, it's a very reliable way of knowing that there's impending doom coming. Yeah. And the S is straining. So when people are having to use their tummy muscles to overcome the failing detrusor. So in general practice, there's a questionnaire you can give, which is the International Prostate Symptom Scorer, of which those are the 7 questions. And it's a great thing just to hand out in your waiting room as a screening tool. And that classifies people as having mild, moderate or severe voiding symptoms. The mild ones you may not have to worry about at all. And the moderate and severe, you're trying to find who's got real problems before they block up and really damage their bladder. And it's really, really important in country patients, because you just don't have the access to the tests and investigations, and people will generally leave things until they're really bad because they don't want to come to the city. And we've got to try and make sure that they don't wreck their bladders with these symptoms.
And that's very readily available or downloadable?
Yeah, it is. So there's a copy up on my website, which you should be able to download. And then the flip side of that, we've got on our handouts is the International Index of Erectile Function, which again, patient administered. That's my vascular screening questionnaire, because it's all around erections. But you should be able to find them online at the Prostate Symptom Score.
Now, I've also been seeing a couple of patients with renal cell cancers. Mm-hmm. One of them was an incidentaloma, and one of them's on your operating list sometime very soon. Can you just walk me through when they're incidental and when they're not incidental? To me, renal cell cancer sounds pretty jolly scary.
Yeah, well, look, I think most of them now are found by chance.
Mm-hmm.
You probably remember medical school, it was hematuria, loin pain and a flank mass was the classic presentation. But the most common thing that we find now is a small renal mass on an ultrasound done for another reason. And that's the most common type of renal cell carcinoma that we see. The symptomatic ones are a lot rarer, and the ones that cause hematuria are a lot rarer. And we approach them differently. So we're doing a lot of renal saving surgery. So we just remove the tumour. And in kidneys, that's pretty much standard of care now. Again, that's become a lot easier through keyhole surgery and robotics, and it's made it safer and so on.
So they're not all looking at a total nephrectomy like they were 20 years ago?
Not at all. In fact, we really try hard not to. Even people who have multiple renal lesions, unless it's a high-grade cancer, they will do just as well if we just remove the tumour. And we're able to remove the tumour with a couple of millimetre margins, repair the kidney, and we do this while we clamping the kidney so there's no bleeding during. We do it very quickly, so it's a very short, warm ischemic time, but that's been a pretty good advance over the last 10 years.
When do you not remove them?
When they're not cancer. So about 20% of these small renal masses are not cancer. So if the patient's younger, we often biopsy them, and there's another condition that mimics it called oncocytoma. We sometimes have to take those out, but most of the time we leave those alone. And in older patients, if you've got a small renal mass, it's really okay to watch them and do interval imaging, do another ultrasound in 6 months. And if it's growing, it might be significant. If it's not, then don't worry. Some of the ones in older people, we even don't take them out, but we can treat them with ablation. And again, you can cook them, you can freeze them, or you can zap them. The best technology that we've got is probably the cooking. And I say the one that we've got because that's the one the radiologists have in our hospital. And you can very reliably target that with CT, know that you're in the right spot, and then destroy the lesion. So in older patients, small renal masses, they're avoiding surgery altogether.
So it's a little bit like doing a rhizotomy with CT control?
Yeah, similar.
Same kind of thing?
Similar, yeah, absolutely. And look, even in patients who aren't very fit, you can do other things like embolization, or we take out big renal masses, we take out the whole kidney. If you've got multiple and we think that we'd have to clamp your kidney for too long, we take out the kidney. But we're trying to save them because, a bit like we were talking about before, life's better with testosterone around. Life's better with 2 kidneys. Yeah. People feel better. They get less complications. So many of our patients now, they're living so long, hypertension, diabetes, all these other major renal risk factors are out there. We should do everything we can to keep nephrons.
And what about our younger patients? Could you talk about things like testicular cancer?
Yeah, so testicular cancer, I think the advances with testicular cancer have all been really made around chemotherapy. Testicular cancer often presents late because men aren't great at doing self-examination, and every history I've ever taken from someone with a testis tumour was it popped up yesterday. What we do is we do the primary surgery, which is pretty straightforward. It's an open inguinal procedure. It's a bit like having a hernia to recover from that. Very, very rare that people have disease on both sides, and very rare we have to give testosterone again. It's about a 10% drop in fertility, and we normally would get people to donate sperm before having a testis removed, mainly because of what's coming next. So most of our patients will get chemotherapy now, either single shot chemotherapy for lower risk disease or more significant chemotherapy. And that's been shown to dramatically reduce the incidence of late recurrences, which is always abdominal lymph nodes because that's where the testes first developed. And they're hard to find, and you have to have lots of CTs and follow-up. So there's been a big move towards using chemotherapy routinely in testis tumours.
Super. Survival rates?
Really good. And it all depends on grade and stage of diagnosis. And the type of tumour too. Some of them are just more aggressive and less chemosensitive. But the vast majority of our tumours are good prognostic feature tumours.
What about the patients who turn up with epididymitis? or epididymal cysts?
Yeah.
Or-
So look, two different things, I suppose, and it's just that scrotal pain issue, which is really problematic. I think, look, I use ultrasound a lot to try and get to the bottom of what the diagnosis is with the scrotal pain, because we've got, varicose seals, we've got, orchitis, epididymitis, we've got epididymal cysts, we've got, in younger patients, we've got torted hydatids of Morgagni and all these little things. And the ultrasound is usually so clear that it gives us a good answer. Most of the time with epididymal cysts, I'll try and leave them alone unless they are painful, or let's say someone's a cyclist and they're wearing lycra all the time, or they're a pilot sitting down and they're getting pain. You can aspirate those, very safe to aspirate, and they very slowly recollect. So in some older patients, a really good way of dealing with it. Might take 6 or 12 months for it to come back. Epididymitis is largely infective. It's usually bacterial, and it usually responds to broad-spectrum antibiotics. But you've got to give it for a long period of time because it's a different part of the body. The immune system's different, and it's protected from the immune system so that we don't develop anti-sperm antibodies. So you need to use something that's going to penetrate tissue well. So I'd use something like cotrimoxazole, sometimes doxycycline in younger people, or ciprofloxacin. And you've got to use it for a long time.
And using it in full dose for a long time?
Yeah. It's quite a significant thing. But my favourite drug for epididymitis is an ice pack. Mm-hmm. Because if you can take the inflammation out of it, the vast majority of their symptoms go down, and the antibiotics will get in better and faster, and their symptoms will settle very quickly. And it's such an easy place to ice. But they've got to ice it religiously for 48 hours. So I tell them to have 3 packs of frozen peas, 2 in the freezer and 1 down there. And they just rotate them around, lie on the couch for 48 hours, and it settles down so much of it.
That's a really good tip.
Yeah, easy, cheap and good.
Easy to do.
Yeah, I like those things.
Yeah, a lot of my post-vasectomy patients say, will a cold beer do?
Yeah, no.
And I'm one out of the fridge on your nuts and the other one down the hatch.
Well, that's where the ice pack comes in, is that you rest the beer on top of the ice pack. So it does 2 jobs at once.
Excellent. I shall let the patients know. When you said a long time, 6 weeks long enough?
4 weeks, I normally do. Yeah.
And do you do anything about hydrocele?
Again, it depends if they're symptomatic or not. Hydroceles are less rewarding to aspirate. They usually come back within 48 hours. Sclerosing doesn't tend to work very well, so we often operate on them. The biggest problem with hydroceles is they take up a lot of space, and your body wants to fill that space up again after you've had your scrotal surgery. So hematomas are a real issue. So anyone I do a hydrocele on, I would always leave a drain in at least overnight just to collapse everything back down again. So if you are doing these yourselves in regional hospitals, I just really would recommend the drain, because it's a very straightforward procedure to do to resect a hydrocele sac. Leave a drain in, put it on high suction, and you won't have problems.
Super. Good to know. Got any advice for our patients going for vasectomy?
Make sure you want it. I think that's the biggest issue. Regret after a vasectomy is probably the biggest thing. I think some patients are taking a bet each way. And when I say make sure you want it, I think some people...
Bet each way, you mean they have one side done and then come back 6 months later and find out if
thanks
they
for pulling me up on that. No, they're donating sperm. They're donating sperm. And I think that's when the man's not sure he wants to give up his fertility, but his wife wants to come off the pill or whatever happens. If they're not sure about the relationship, all those sorts of things. And so I paint the scenarios that, you lose all your kids tomorrow in a car accident. Would you want any more kids? And if they say no, I say, right, perfect operation for you. And if they doubt it, I say, well, you can donate sperm if you want. Or there are other things we can do. Have you heard of a Marina coil? Have you heard of Implanon? Have these things been discussed? And I think that's the most important thing, is just make sure that the man is having a destructive permanent operation. He needs to be happy that he's having that done. I think the rates of everyone gets epididymal dysfunction afterwards. The fertility specialists hate vasectomy because even if you reverse it, it doesn't work very well, because the epididymis goes from being this efficient long highway for sperm to mature along to being these lakes of where sperm just bump into each other and the forward progress is not so great. So sperm quality deteriorates after vasectomy, and that's why you need to donate beforehand. So, yeah, make sure it's what you want to do. I think if a GP is good at doing vasectomies and they're comfortable doing them, no problem whatsoever with that, and doing them under local anaesthetic is just as valid as under a general. Lots of ice, favourite drug afterwards.
Oh, yep. Hence the ice pack.
Yeah, definitely.
Tight jocks.
Definitely.
Small pack of frozen peas.
Yeah. And usually do it on a Friday and make sure they don't go back to work till Monday.
Yeah. And if they're a farmer, then put them in bilateral plaster casts on their legs so that they can't go out and do sheep work when you don't want them to. The other things that I'm seeing have been kind of a bit odd. I've seen a run of patients from nursing homes with long-term indwelling catheters who are getting SCCs on their foreskin.
Oh, right. Okay.
And I'm just wondering, is this irritation from the indwelling catheter? Is there something we can do to prevent this?
So SCC of the penis is really linked to chronic irritation, and even sort of in the urinary tract, it's the chronic irritation that causes the schistosomiasis, bilharzia type bladder that gets SCCs. It's the chronic UTIs. And what I do find in patients who are in nursing homes is there's not good hygiene of the foreskin. People aren't pulling it back. And when I see these guys come in for their cystoscopies every 6 months or so, they've often got a lot of squames that have built up, and they've got this chronic inflammation that's going on there. So I think that's probably what you're seeing, and that's why circumcision is protective, is that you can't get that build-up, you can't get that moist and that inflammation. So it's probably a nursing issue more than anything. The IDC itself is not really in that region.
So that's going to be one of those things where it just seems a bit extreme to kind of have to justify an adult circumcision in a wax hospital because of a hygiene issue.
Yeah, absolutely. And maybe it's part of the protocol of having an IDC, or a man who's not capable of looking after himself, is that someone is pulling the foreskin back once a week and just letting water run over it, just keeping it clean.
Well,
that's all it is.
It's a good simple solution, and it saves them a lot of pain from a circ when they're already a bit demented.
Yes, yeah.
One of the other things that I have come across a little bit, and probably going back to your thing on bladder function, patients getting Botox. I know they're all kind of excited, and they're going, "Oh, I'm going to have a wrinkle-free bladder." Available?
Yeah, no, absolutely, it's available, and it's a walk-in, walk-out kind of thing. Botox is a very interesting molecule, I'm sure you know. We're using it in that setting, or we think we're using it in that setting as a muscle paresis, but that's not actually true. What Botox does is it stops nerve conduction. So what you're doing is you're denervating the bladder, and especially the trigone of the bladder, so that you're reducing the sensation and even the power of the void. So the overactive bladder, which can be this complex of a more sensitive bladder that also then pushes really hard and people get urge incontinence, can be treated. Most people get 3 to 4 months out of an injection. Botox has been used and can be used to treat tight bladder necks instead of taking Flomaxtra or Prazosin. It's been injected into prostates because you get glandular involution. So people with very prominent glands sort of around the face, the cosmetic guys actually inject submandibular glands with it, and they really shrivel up, and the prostate's a gland, and it shrinks when you inject it with Botox. Problem with Botox really is it's expensive, and it's a short term. It's 3 or 4 months. You've got to use 100 units at $5 to $10 a unit. The other problem is that most men anyway who have an overactive bladder have it as a secondary side effect to obstruction. So you fix the underlying problem first. And it might look like, they don't have a big prostate and they've got this heavily trabeculated, thick-walled bladder, but they've been obstructed. So once you fix their obstruction, their bladders do get better. But it's a good treatment for that intractable incontinence, and you don't have to take an anticholinergic. You don't have to take, something like Betmega. And those drugs are $60, $70 a month, and the old-fashioned oxybutynin has lots of side effects, and people don't stick with it.
Tom, do you have any final words for us?
Well, I think the only other thing we haven't talked about is kidney stones, because there's a lot of those around, and how do you know what to treat and what not to treat? As a general rule, if you do an ultrasound, you find a kidney stone. If it's not causing any symptoms, don't worry about it, especially if it's in the lower pole, because they have to sort of move up and then down. So kidney stones are a problem when they engage the ureter, and they block the ureter and they generate a very high pressure, which is painful. They're not really a problem otherwise. So if you're not getting UTIs, if you don't have a large volume of stone burden, and you've got a little fleck of calcium in your kidney and it's not causing any symptoms, you might tell them, but you don't have to do anything about it. Symptomatic kidney stones, your management's going to depend a bit on what access to imaging that you've got. Certainly, your bad pain is usually only going to last for a few hours. So good analgesia, and then get some imaging done. Plain film ultrasound's okay. CT scan's much better, and most regional centres can give you that. And I think you want to identify those guys who you think might be able to pass it out themselves. The smaller the stone and the further away it is from the kidney when you find it, the more likely it is you'll pass it. Yeah. So big stones that present in the upper ureter, you're probably on a hiding to nothing. The smaller ones, bottom 2/3, certainly if you pass the pelvic brim, there's a good chance you're going to pass it. There's some evidence of putting people on Flomaxtra can relax the ureter and let it pass through. You've got to send them up to Perth if they get an infection, if they get a fever, or if they are having intractable pain, or you're just not seeing progression of the stone. But otherwise, you could manage those yourself. Collect it if you can. Send it off for analysis. Get all your patients who've had stones to have a vitamin D, because there's that secondary hyperparathyroidism of low vitamin D, and in general practice, low vitamin Ds are super common. Fix their vitamin D, you fix their calcium levels. You do an ionised calcium, just a total calcium. Do ionised calcium, uric acid, and phosphate. Lots of your patients will have high uric acid levels, and I like patients who make kidney stones to have low uric acid levels, because it reduces gout and inflammation, and a lot of these guys are getting it and not telling you they're getting gout. Plus, it will really just take kidney stones out of their lives. If they have a low uric acid level, it's not about drinking tons of water, it's about drinking enough water, or more importantly, about avoiding dehydration, so that they plan when they're going to exercise or work outside and so on. Get the uric acid level as low as you can. And with allopurinol. Just with the allopurinol is the trick. Tablet once a day. The trick with allopurinol, though, is that the dosing changes from one patient to another. Yeah. So one guy might need 100 milligrams a day, another one 600, and there's no rhyme or reason. So you actually would titrate their allopurinol with their uric acid levels? And definitely, but it's a bit set and forget. So I put everyone on 300, and then I see them in a month and see where their urate level is. Mm-hmm. And then I'll either drop them back down to 100 or go to 600. Now, allopurinol is a rash. You either get it or you don't. Otherwise, it's a really good antioxidant that's really safe. Yeah. And there's a link, as you probably know, of high uric acid levels and coronary vascular disease. Yeah. So again, we're getting back to, most important thing is looking after their vessels. So most of kidney stones can be managed in general practice, can be managed in the country, and reducing risk for kidney stones is really a lot simpler than you might think.
Tom, thanks so much for joining us today and for your words of wisdom over a vast number of topics.
Pleasure. We could go on all night.
We could.
Thank you.